Okay. Thank you, Jonathan. Yeah, good afternoon, everyone. This is a project which we're using adult social care data to try and understand people's transitions between different kinds of care packages, and we're hoping that would be useful for planning future adult social care provision. So I'd like to thank my colleagues Cheyenne and Avashi from Brent Council. And yeah, if there's any time at the end, I'll answer questions, but do feel free to pop them in the chat as we go along. We've got an annual spend of about £90 million in the care at home and about £38 million on residential care each year within Brent Adult Social Care. And the new requests for support have been rising each year about 5%. While the majority of adult social care users are 65 and over, the growth is actually most rapid in the working age population. So we wanted to do this work to try and answer a few questions. What kind of care provision is going to be needed in the future in Brent? For example, how many care home places are we going to need? And how long are users staying in different kinds of care packages? And what does that look like for different segments of the population? And hopefully this is going to help us understand maybe what proactive or preventative measures we can take to prevent people from escalating into more intensive kinds of care. And then, yeah, is a multi-state model a useful method here? This is a new method for us, so we're, I suppose, trying it out rather than claiming to be experts. So the data we've got is all Brent adult social care clients at some point between January 2020 and December 24. And we used a fantastic resource, which is the Whole Systems Integrated Care Data Resource, which has got records from over 2.4 million patients in Northwest London. So that's linked GP data, hospital data, some community data, and some social care data. And we use the de-identified patient level version of the data set. So we've got 4 states that we've modelled. Care at home, which includes like low level packages, extra care, and then supported living. We've got residential care, which includes residential and nursing care. We've got people that are not currently adult social care users, so they might have no care, or they might be receiving just informal and paid care. They might be self-funders, or they might be getting the NHS continuing healthcare. And so people are allowed to transition in either direction between those 3 states. And then there's the 4th state, which is deceased. So yeah, as I say, we've got the longitudinal individual level data, and we're using that to see how many transitions people make between different states. So we've taken the state, the last known state for that year is taken as the state for the whole year. So we're ignoring any sort of within year transitions, and we use the R package MSM to do the modelling. So that's a package that assumes that the current state, the transition depends only on the current state, and various other assumptions that I'll describe at the end. So far, we've only included demographic covariates. So we've got gender, age, deprivation, and ethnicity. We had a few challenges with the models not converging, so we've had to only include ethnicity as very broad categories and only age in 2 groups. So we've got about 7,000 adults with the complete data. About 2 in 3 are age 65 and over, and slightly more are female. We know that people from Black ethnic groups and from deprived areas tend to be overrepresented in adult social care compared with the census. And we also know that our older clients live in slightly less deprived areas compared with our younger clients. So there were about 26,800 transitions over the 5 years of follow-up. So at baseline, there were about 5,000 people that were not receiving a package, about 1,500 people that were receiving care at home, and about 500 in residential care. And then this is the table that's showing what the transition probabilities look like over 10 years. So you observe it for 5 years, and then the model predicts the following 5 years. So just to explain what this means, If you take the care at home group, for example, so at baseline they're receiving a care package in their own home. 42% of them are not receiving any care at year 10. 22% are still receiving care at home. 4% have moved into residential care, and 32% have died during the 10-year follow-up. Sorry, I should have got myself some water. And then we've gone on to look at the demographics that are associated with each of those transitions. So first of all, thinking about making a move to a more intensive care package. So moving from not in social care to care at home. And you can see that this is more likely for so things to the right-hand side mean that those people are more likely to make that transition. The younger people from Black ethnic groups and Asian ethnic groups are more likely to make that transition. And people from less deprived areas and males are less likely to make it. And then down the bottom, we've got people transitioning from no care to residential care. And this is sort of the mirror image. So younger people are less likely, and Black and Asian groups less likely to make that transition. So these are transitions that are about, well, they should reflect greater care needs. So people having increasing need for care, maybe because they're getting more frail or have an onset of a new condition. But the specific kind of support that they're going to get is going to depend on their main reason for needing support. So whether it's mental health or physical health, whether it's dementia or sensory. And it's also going to depend on the other sources of support they might have, like family and friends. Oh. Then this is looking at the factors that are associated with a transition to less intensive care. So these are people that have moved from care at home to no care. And this is less likely for younger people, Black ethnic groups, males. So it's quite difficult to interpret this, I find, but I was sort of turning it around a little bit. It means that older people, white ethnic groups, and people in more deprived areas are more likely to be making these transitions. And this might be because they've gone on to a short-term reablement package after a hospital discharge. So actually, these transition probabilities are maybe reflecting that they've had that hospitalisation and then they've had that short-term care and now they've moved out of it. And then similarly down the bottom, transitioning from residential care to no care is less likely for Black ethnic groups. And again, so it might be that white ethnic groups are transitioning out of short-term packages after their hospital discharge. And they might have to go into residential care for just a short while, either because their families are not able to provide support, or maybe there's like self-neglect or other challenges in the home. And then this is transitions from either care at home to deceased or residential care to deceased. So this is less likely for younger people, less likely for Black ethnic groups, more likely for males. And that very much reflects the life expectancy patterns that you see nationally. And then down the bottom, it's quite interesting to see the Asian ethnic groups, they tend to be in residential homes until they die. This is an approach that also can give you sojourn times, which I don't know how useful it is with only the 5 years of follow-up, but it calculates the total amount of time that a person has spent in each of the different states. So you can see here that people from Black ethnic groups are slightly more likely to have a longer stay in adult social care. But the differences are not statistically significant. But that's something we're going to probe a bit more to try and understand if there's any inequalities or sort of disparities going on. So yeah, just moving on to the assumptions and limitations, really. So I've mentioned the probability of the next transition is assumed to depend only on the current one. I think that's a reasonable assumption, sort of conditional on the things that are the covariates that we put in the model. But another assumption is that the transition probabilities are constant over time, and that seems to be a really quite major limitation because this is obviously covers the period of the COVID pandemic. We had a lot more than usual transitions to death and an increase in requests to adult social care. So I think that's something that I really need to take account of in the future modelling. Obviously, I've said this is just a Brent local authority perspective. There are other kinds of care that are not included. And we've had to simplify the data a lot, so we're not including some kinds of packages. We have lumped together care at home, which goes from sort of 1 or 2 hours of care a week, right through to having your own front door, but in a warden-controlled home. So really a lot of heterogeneity there, probably. I've mentioned that we're only looking about end of year transitions, and so within year transitions are ignored. And yeah, I've only included people for these 5 years of follow-up, and I'm just sort of trying to think through what that means for the long-term projections, whether that's useful or a bit of a limitation. So implications, we're not really there yet, I would say. So this is just an initial attempt to use longitudinal data from adult social care. It's something that we haven't really done very much yet within the borough. So yeah, looking forward to hearing other people's experiences. But one of the things we wanted to do was to look at trying to reduce those transitions into more intensive care, and particularly from care at home to residential care. But we actually didn't find any of the demographic factors were related, so we haven't so far found any features that are associated with making that transition. So I think something we want to do next is to incorporate health conditions and health trajectories, because we've got that linked data into the NHS, that's possible. We would like to use a new index of multiple deprivation scores, think about that care at home in a bit more detail, and maybe use alternative modelling approaches. It's been suggested to me that neural networks might be a way to go, but I have no idea. So very much, yeah, very much welcome any questions or suggestions as to how I might take this forward. So please do get in touch if you're using similar data. There is the question, did I look at health conditions? Yeah, that's one of the next steps. So I haven't looked at the reasons why people are going into adult social care at all. But yeah, bringing in that health aspect is really important. I did look at hospital admissions, but I haven't sort of thoroughly looked at it yet. But it didn't seem that hospital admissions, that I mean, it wasn't that everybody that had an adult social care package was related to hospital admission. I need to tease that out a lot more. Yeah, so not receiving adult social care to us, here, this means that they're not getting local authority adult social care. So either that's because they're self-funding, or they are maybe getting informal care just from their family and friends, or they are not needing or getting any care at all. So that's a really big heterogeneous group as well. So yeah, that is a good point, that as well as the other things need to be separated out a bit more. But obviously, it's really difficult to get information on those things. Why we don't have good data on self-funding and informal care. Yeah. But very much a local authority perspective that will hopefully inform our provision, but it's not for wider generalisability. So can we distinguish residential care and nursing care? Yes, we can do that. We know what kind of care home they're in and what kind of package. I suspect the numbers might be a little bit small for us to do a lot of probing into what's related to those things. And another extension to this analysis would be maybe to look across the whole of North West London rather than just the Brent Borough, because you'd then be getting more numbers. But I think there's maybe a challenge of that as well, in that not every borough sets up its adult social care data in the same way. So think that would be something that we'd really like to do. I think maybe Imperial actually is thinking of taking this forward, so they probably have more capability to look right across the boroughs and do some more advanced modelling.
Thanks, Martha. That's a really good answer. I think we probably have time for just one more, which is David Ellis asks, and it's just a clarification, I think. Did you have the one base set of conversion probabilities that were then modified for each specific group? Was that based on the data or existing literature?
So if I understand the question correctly, did we just start off with one initial set of starting values, and was that based on data or the literature? We just had one set of values, yes, which was based on the data. So if that's a big limitation, do feel free to email me and let me know how to do it differently.
Thanks very much, Mai. Just bear with me 1 second. I think we might be... Are we ready to move on? Can somebody let me know? I think maybe the answer is no. So if you don't mind, perhaps there is another question I can find for you. If there are any other questions in the chat, please let me know. Seen a couple of people saying that it looks like a really great analysis. What do you think about this as a research area with the problems of small budgets and increasing demand? Is what's it like as a researcher?
So I think the question is, what's it like as a researcher with limited budgets? I don't know if that refers to limited budgets for adult social care or for research, but I'll answer it from the analyst point of view. I hope I've understood the question correctly, but yeah, it's quite difficult in local authority when you're trying to learn a new method, I think. Obviously, we're quite a small team and we don't have huge statistical resources, so collaborating with universities or some other organisations that have done this modelling is really what we need to do. So I'm really hoping that this is a chance to connect with other people that are doing similar or grappling with similar kinds of problems. As I say, the adult social care data has got quite a lot of potential, but I don't think it's been realised at all within our borough yet. So yeah, it feels like maybe social care is a little bit further behind in terms of, maybe compared to the NHS in terms of what we're doing with the data.